I was really impressed yesterday by one point that was addressed by Steve Chu, and the point was the point that he called science or propaganda. He was saying something about what we find in lectures, and there may be science and there may be propaganda. And actually, I don't like propaganda in lectures. I mean, we all have some propaganda to do, but I don't like that very much. So I would love to speak only about scientific facts. And when it comes to occlusion, as it is for many, many different subjects in dentistry, the point is how much science do we have actually? Because the point is that many, many times we would love to talk with some evidence, but it gets difficult to get the good level of evidence. That means that it may be difficult to have high quality studies, to have systematic reviews of randomized controlled trials and all the stuff that we know is related to science. So I'll try to give you some information that can be considered scientific, and I'll try to do this in this 60 minutes. Some of the science about this you can find in a lecture that is presented on Dental XP website. That's a lecture about occlusion in implant dentistry. And if you have seen that, and if you have not seen that, you can find maybe more specific information about science in occlusion. In these 60 minutes, I was willing to do something a little bit different. That means I'm willing to share more clinical cases experience, because I think that it can be a better occasion to talk about clinical cases than just to look at literature and to look at all the things that have been published on this topic. And yes, we would love to speak about occlusion with some science, but as you can find in many, many articles, I'm just citing one that I really like because it's kind of a very big review article about occlusion. Conflicting opinions exist concerning a number of common procedures in clinical dentistry, mainly due to a scarcity of good studies with unambiguous results. So this is a paper mostly about occlusion by Gunnar Carlsson, who had been the chief of prosthodontic in Karolinska Institute in Sweden, and that's what he's saying after all his life working on this topic. So where do we start to talk about occlusion? When I was younger, let's say 25 years ago, when I graduated in dentistry and I started to work, I had a chance to have this book. That was the Italian edition of a book by Neil Guichet, and the title was Gnatology Everyday Dentistry, and that was translated in Italian. And I had this because my father is a dentist, and I had a lot of old books about this. And what was this saying? This book actually was saying that you need to treat patients to correct their occlusion. That means that you are doing restorative treatment to correct a bad occlusion. Because if the occlusion is not good enough, the patient will become a Braxer, will destroy its own teeth, and things like that. And that is what things used to be back in the past, where we come from. And the concept of treating patients to correct a bad occlusion and maybe doing a big prosthodontic work because the patient does not have a good occlusion is still a concept that is somehow popular in dentistry. And this concept can be really misleading. So the point is that I don't want to get into this kind of wrong way. I just mentioned one thing, history. That means that this is a historical book, and I want to share something personal with you this morning. Actually, this is my father. This is not me, this is my sister. She is 18 months older than me, and she is a dentist like me, and we have almost been growing in a dental office, and that was funny. And this is actually my father university book, 1951-52. That's the time he was graduating in dental school. And this was the first brand of his office. I was talking with my friend Miguel Stanley about branding, and that was the way branding used to be back in the 50s. And I'm showing you this just for one reason, because my father, he's turning 90 years old tomorrow. And when I will be back in Italy, he will ask me, you have been at a meeting, have you seen something new? Because every time he asks, have you seen something new? So I was just willing to share this thing with you, and I was willing just to say happy 90th birthday, Dad, because tomorrow it's his birthday. So actually, what's the point with correcting bad occlusion? Look at this patient. He has a lot of occlusal wear. And look at the way he has been wearing off his anteriors. And this is in 2015. So actually, look at his upper incisors, look at his lower incisor. He has been wearing a lot of his teeth. And we could think about how to treat this patient. And we could think about how to rebuild anterior guidance, to do a lot of things. But the point is that we need to look back in the story of this patient. Actually, this is the same patient 11 years before. And you can see that he has exactly the same amount of wear on the occlusal surfaces. And this is 2004, and you can see that he was having exactly same kind of wear. And you can see that nothing has been changing in 11 years. So 2004, 2015, 11 years. I think that this is a concept of minimal invasive dentistry, because we have not been doing anything in the mouth of this patient. The only things that he has been using, he has been wearing a night guard, because he is a heavy braxer, he has night braxing habits, and with night guards, he has been changing a couple of them. He has been using night guards since 1996. I have his pictures only in 2004, but I've been following this patient for over 20 years, and we have been doing nothing in his mouth, because we don't correct a patient occlusion with prosthodontic treatment. We need to do prosthodontic treatment for several reasons, but the main reason is never to correct an occlusal issue. So in 2017, this year, I had the chance with my friend Daniele Manfredini, who is an excellent clinician and researcher about TMD. We had a chance to write this systematic review about prosthodontic planning in patients with TMD disorders and or bruxism. And you can find in this paper a very good review of the existing literature about the issue of correcting occlusion to treat TMD and bruxers. And the conclusion of this paper is very specific. The concept of correcting occlusion should not be the reason for restorative treatment. So we are not doing prosthodontic treatment to restore the occlusion of a patient. That does not mean that we are not changing occlusion of patients. And so actually we have several conditions, clinical conditions, where we do restorative treatment in patients. Look at this patient. He is over 75 years old, but he is a very nice guy, very lively person. And he came in my office with this kind of clinical condition. He has a lot of wear. He has some old prosthodontic treatment back in the lower molar area. And he is willing to do something because he has pain in one bridge in the posterior area. He has some pain here. And he is willing to change his aesthetic. So we start from an evaluation of his clinical condition. This is the area where he is feeling pain, but he has also some problems here. you can see that he has a lot of wear, but he has overall a good-looking prosthodontic periodontal condition. So we started to plan treatment for this patient. So as he is willing to correct his aesthetic appearance, we started to do an evaluation of his aesthetics. And with the mock-up, we look how we can change, we discuss with the patient, and when we have found what is a good solution for his willing, we start treatment. So we start with preparing his tooth, we apply a provisional, we did some scans, and on this scan, we plan to do all single unit crowns, and the patient has been treated with single monolithic zirconia crowns. They are multi-layered monolithic zirconia. They are just a little bit stained and nothing more than this. And you can see that we started from this condition. We have been placing 2 implants in the posterior. We have not been doing any endo, of course, because nowadays it's useless to do endo for making crowns. There are a lot of materials that does not require so much preparation. So we did full crowns in these patients, and we did them with multi-layered monolithic zirconia, which is a translucent type of material, which looks extremely good. So there are clinical conditions where we change the occlusion of the patient, but usually this happens within an overall treatment plan. And you can see that we are now in 2 years after treatment of this patient, and this material is looking quite good. I was talking about monolithic restoration with Pinchas Adar in San Diego, and we were saying that this material looks extremely good in the mouth of patients. Sometimes it's difficult to make pictures, because with zirconia, if you take pictures, they look usually less bright than they do in the mouth of the patient. But look how much we have changed this occlusal condition of this patient. So we are not saying that you must not do prosthodontic treatments. We are not saying that that occlusion is not important. Occlusion, of course, is important in dental treatments, but the point is that we are not starting a treatment just to change the occlusion of a patient. We are starting a treatment because of overall requirements for restorative reasons, for periodontal reasons, for aesthetic reasons a lot of times. So we restore occlusion, but we restore occlusion within a treatment plan which is specific for that patient. And this is the most important take-home message that I want to stress, because many, many times we still see people treating cases just because the occlusion is not looking good. And that's absolutely crazy. We can call these aesthetic treatments because they look good aesthetically, but they are not medical treatments at all. So when we restore patients, how do we make our restorations, and what type of occlusal concepts are we using to make our prosthodontic treatment work in the long run? And to talk about this, I want to share with you another clinical case. This lady came to my office in 2004, and she had been treated years before by another dentist with a bridge in the upper anteriors. She had some endo problems here in the lower. She had some missing teeth here. And she was willing to do some treatment to fix things not properly working. Here she had problems with decementation. Here she had problems. So she was willing to fix several things. So we developed a treatment plan for her. And treatment plan was to redo all the old prosthodontic work and to do some new prosthodontic work where things were not okay. So we removed everything. We did new preps. We did new endo. We did some crown lengthening procedures according to periodontal prosthesis concepts. This is the way she was looking in the upper after prosthodontic and periodontal surgery was performed. And this was the time of upper impressions. And when we had to manage her occlusion, actually what we did was a full recording, pantographic tracings. Actually, this patient was treated according to individual pantographic tracing. And this is an old Denard pantograph. And this is an individual face bow. So these are things that come back from the past. And there is no science on this. Actually, there is no science at all, but they are tools that sometimes can be useful in treatment. Sometimes you can avoid to use all this stuff, but sometimes you can have a good help from using this stuff, but there's no science in this. And you see here she is with the upper full arch. This is metal ceramic restoration, and in the lower she has a crown and bridge somewhere else. And here she is 10 years later in 2015, and you can see that the level of the bone is actually doing good. Everything is doing good. Here everything is doing good. And the point is, how much role has occlusion in this? I mean, we have had periodontal surgery, we have had some endo treatment, and everything was done in a proper way. But look, everything is working extremely good 10 years later. So how much occlusion is important to this? Actually, it's a difficult question. The title of this presentation this morning is The Role of Occlusion in Implant Prosthetic. It's a difficult question because we have so much difficulties to find some scientific information about occlusal issue. And sometimes we feel that occlusion has been important in the success of a treatment, but it's really hard to tell. So if we don't have any chipping of ceramic, if we don't have any problem with excessive mobility of teeth, probably occlusion has been handled in a proper way, but it's difficult to say this with scientific-based facts. So when it comes to implants, what is the role of occlusion in long-term success of implant? Look at this implant crown. This is absolutely nothing special. It's a standard implant and it's a molar crown. And actually, this is, at the time this implant was placed, and you can see it's a standard external hexagon implant, and you can see the bone level is not that good. This implant has been placed by myself, but I was not taking care a lot of the level of the bone. But here is a funny story about this implant, because actually, this is at the time of placement, 2007, 2008, this was the provisional. 2013, this is the crown 5 years later. And here we are in 2015, and look to the level of the bone of this implant. It's a standard external hexagon implant, and the bone level is just amazing. Looks like bone remodeling has led to kind of growth of bone. And has this something to do with good tissues? Has this something to do with a good occlusal load on that implant? We actually don't know, but maybe occlusion can play a role in the long-term stability of our treatment. So coming back to the title, what is the role of occlusion in implant prosthetics when we see it in the long run? Probably there is a big role of occlusion in the success, but actually the point is that it's difficult to tell what is specific about occlusion. Yesterday I liked a lot Steve Chu's lecture because he said something about people are saying that this is the best connection, people are saying that this position of the bone of the implant level is really important, people are saying a lot of things, but then you can find cases done in a totally different way and they have huge success. And sometimes you see cases done in a way that should be the best way according to current trends and fashion in implant dentistry, and it's not working just. So there are a lot of things that probably we still do not know. And coming to another clinical case, this lady came to my office several years ago, and you can see how bad she is looking. And actually, this bridge in the lower, which is this one, she used to place it in the mouth and take it out because the root was going into this hole down here, and she was placing it there. And this lady, she is the head of the scientific department of a very big consultant firm in Italy, which is an American consultant firm in Italy. And this lady has a PhD at MIT, and she is extremely intelligent, but she has not been taking care of her health completely for many, many years. So we started to do treatment plan for her. So we took impressions. On these impressions, we developed some kind of template to check how we should change things. And with this template, we did a CT scan, and we checked all the positions where we could place the implants. And then we went for surgery according to this. So in one appointment under general anesthesia, I placed all the implants in the upper and all the implants in the lower, and took impressions for immediate loading in the upper and in the lower. And you can see here that a split crest was done, and a split flap was positioned to the buccal, and impressions were taken, and these are the provisional 24 hours after the time of surgery. So these are the provisionals. Here you can see there is bleeding because it's just 24 hours after surgery. And you see we have placed several implants. Here we have had also sinus lift in this area. Here we have had sinus lift. Here we had to place short implants because the nerve was not clearly visible on the X-rays, on the CT scans. And you see that we have been changing quite a lot her clinical condition. Here she was 1 week after implants were placed and the provisional was delivered. So with this, we waited for 6 months. This was the way she was looking with the provisional. And here you can see how it was looking 6 months after waiting with the provisional in the mouth. And you can see that the soft tissue is extremely healed around the implants. And you can see that when we take off the provisional, the way the tissue looks, it's with epithelium. Here you can see everywhere there is a nice looking epithelium. There is not much blood. You hear sometimes people nowadays are saying that you need to see blood every time you disconnect an implant, because if there is blood, it's good looking. Here there is not much blood. It's almost completely with epithelium. So we took final impressions in the upper, in the lower. This is a bite registration with just some mounting devices. These are the master model for the final restoration, and these are the steps of trying of this metal ceramic restoration. Here you can see in the upper and in the lower the structures. This is just a check of occlusal position, and this is the metal framework for ceramic veneering. And we had another check for the occlusal position. And finally, we had some check with resin for checking the type of occlusal contacts that we were willing to provide to the patient. We had some aesthetic evaluation. The problem was that her lip was not displaying the same way in the left and in the right side when she was smiling. So we had to manage a little bit with bipupillary line and lip line. And here is the prosthodontic work ready to be delivered in the mouth of the patient, and you can see that there is a good care with occlusion on this patient. Actually, at the time of placement of final restoration, I was disappointed with the technician I was working at that time, because actually I think that the aesthetics of this work was ugly. The occlusion was good, but the aesthetic was not good at all. So here is the way it was after everything had been done in the patient. And you can see that we had implants here with sinus lift, implants here with sinus lift, shorter implants here, and everything was done with immediate loading. And here she is 10 years post-op. And you can see the level of the bone in the posterior areas. She had some missing bone here on this implant, but look how is she looking everywhere. And these are standard external hexagon implants, and you remember how much healed was the soft tissue when we disconnected the provisional. There was no bleeding at all. So people are saying, you need to see bleeding. You need not to disconnect. Look here. There was no bleeding. There was a perfect epithelium. This has been disconnected a lot of time. This is platform switching, which was done just by using a connection, a 4 millimeter connection on a 5 millimeter base. This is 4 millimeter and 4 millimeter base, and this is absolutely the same. And how good things have been in this case. How much is the role of occlusion in this? Because probably the way we are managing things, the way we are loading our implants has some effect on long-term success. So sometimes we are discussing a lot about several issues, and we are having a focus on small issues to say, this is the most important thing to do, but maybe all the occlusal side of the treatment has been not taken care completely. So occlusion has a big role probably in the long-term success of everything we do, but it's hard to prove that. It's hard to give a demonstration. So how do we manage occlusion when we have implants? Let's say we have one crown here on an implant, and in the same patient we have one crown on a natural tooth just on the other side. And this is actually the way this patient is looking. She has one crown here and she has one crown on this side. Or how do we manage occlusion when we are providing treatment in a patient that requires crowns on natural dentition and crowns on implant? And of course, there is occlusion also on untreated tooth. How do we manage occlusal issues in our implant patients? Actually, we should again shift the focus on how do we develop treatment plan for the patient rather than a theory of occlusion. Because actually, the point is not how do you manage occlusion on single implants, how do you manage occlusion on distal implants, how do you manage occlusion in full mouth. The point is how do you manage occlusion in each individual patient. So this is the initial condition in this patient. This is after treatment. 2 implants have been placed here in this area. There was a narrow crest. We did some split crest, and we placed 2 implants, and you see that here is the occlusion on the implants, here is the occlusion on the natural dentition. But again, it's within the context of a treatment. This lady had not been wearing her removable for many, many years, so you can see there is no space here. She has had these old bridges in the upper, and you can see that she had some recession. She was unhappy with the way her smile was looking. So we started again doing treatment plan for this individual patient. So you can see that she's missing here. You can see that she has some problem here. You can see that she has a big problem here on this tooth. And you can see that she has had a lot of periodontal tooth bone loss here in the upper. So we developed an individual treatment plan for this patient, taking into consideration her aesthetic needs, the way we could manage all the treatment of the patient, not just the single issue, no half smiles, like Miguel likes to say. So this was another no half smile treatment. So we redid all the old treatments. We placed 2 implants here in the upper. We did new crowns on the teeth and new crowns, of course, on the implants. Here you can see this is another treatment done with metal ceramic. I was using this till 7, 8 years old ago. Now I'm using it much less. And here again, you can see that occlusion has been developed with very good precision by the dental technician. And you can see that everything is within a complex treatment of the patient. And occlusion is managed within the treatment of this this lady, of this patient. So we have implants here. We have implants here with a sinus lift where there was this missing tooth, and we did a bridge on 2 implants here. And actually, occlusion here on these implants is within occlusion of this patient. So we built a proper occlusion for this patient with anterior guidance, with everything. You know that it's important when you are treating a patient. And so how do we manage occlusion? The most important thing is that we manage occlusion within a specific individual treatment plan. And so we do a specific type of occlusion according to the need of that patient. And it's not a cookbook. I mean, it's just trying to do the best thing for your patient. And I want you to think about one point. What are the consequences of a missing treatment plan? Look at this man. He is in his 60s. This is the way he came to my office. Actually, he was referred by a colleague, and he was unhappy with the way he was looking, his smile. But look at his mouth. He has had a lot of previous dental treatment. And this is the type of patients that are coming to my office. And these are terrible patients, because you can see he has an implant here, he has an implant here, he has implants here, he has implants here, implants here, and he has all these implants in between teeth with big periodontal problems. So he has bleeding here, he has bleeding here, he has bleeding here. Some of his teeth are moving. The implants, of course, are not moving, so he is very unhappy because when he chews, he has food going everywhere. He has a lot of problem to keep clean everywhere. So this is an example of terrible treatment planning for a patient, because if we just think that one tooth is missing, so we place one implant, and we do not take care of the overall condition of the patient, we are going to end up in big, big problems. And the cost of not doing treatment planning for a patient is a very high cost to the patient. Because actually, when a dentist put this implant in the mouth of this patient, he did not completely consider and address the periodontal condition of the patient. And now the patient has big problems. He has a lot of periodontal probing on that implant. He has probing almost everywhere. So the cost of not making treatment plan is very high cost. And every single implant should be placed within a proper global treatment plan for each individual patient. Failing to treatment plan is planning to fail, because every time we place an implant in the mouth of a patient, without a proper treatment plan, we are going to end up in big, big problems. So maybe we are placing a lot of implants that are not necessary. So the point is, every missing tooth is to be replaced. Look at this lady. She has one missing here, she has two missing here. This is the way she is smiling. So she is happy with her smile. So this is the way she is in my office, doing maintenance since 10 years and no implants placed, and she is okay like this. So the point is that the consequence of not replacing a missing posterior tooth are very limited consequences. So instead of placing implants everywhere there is a space, we put an implant. We should take care of the patient, and maybe we place less implants, but we have better long-term results. And you can find a lot of literature telling that if you are not replacing some missing teeth in the posterior, you are not having any problem. And the survival rates of teeth near to treated or untreated posterior bounded edentulous spaces is absolutely good. I mean, there's no need to place implants everywhere. And another point is that the shortened dental arch is a treatment option that is working very good. So we don't need to place all implants everywhere. So actually, the point is that we should place implants within a proper treatment plan, and we should manage occlusion of those implants within a proper treatment plan. And the treatment plan may be to do a completely new kind of occlusion, or maybe to keep the same kind of occlusion. That means that we are going to keep maximum intercuspal position of that patient, or maybe we are doing a new treatment, building a new occlusion in centric relation. But the most important thing is that we should do all things within a proper treatment plan. So after we have done a proper treatment plan, of course, there are questions specific to the implants. Is an implant equal to a tooth from a occlusal standpoint? Is there a specific type of occlusion for implants? If we have one implant and one tooth near each to the other, should we manage in a different way? How do we manage occlusal issues in our patients? If the patient is a Braxer, for example, what are we doing with our implants? How are we managing things? So, to talk about this, we need to look a little bit into the literature. And as I told you before, if you want to have more details about all the literature on occlusion, you can go to the Dental XP website to get the lecture about occlusion, and you can find a good description of all the papers that I'm showing you here, because there are several papers about the way to manage occlusion on implants. And you can read them, you can find them in that literature review on Dental XP. So the question is, what is the synthesis of all the papers that have been published? Actually, of course, the first point is that a tooth is not an implant from several points of view. The most important one is that, of course, we have periodontal ligament in the tooth and we have osseointegration on the implant. And the second point is that the mobility of a tooth is a high mobility, 25 to 100 microns. The mobility of an implant is very, very low. It's almost non-existent. And 25 to 100 microns, it's something that can change. And this is very important because we all know that people have different mobility of their dentition during their life and during maybe different period of their of the day or of the month or of a year. So the natural dentition is able to adapt to a lot of things, and of course implants are not able of having same type of adaptation. Then there are several other differences. The most important one is proprioception. On tooth, we have periodontal mechanoreceptors, so we have a very strong capacity to feel things that we are biting. On implants, we have no proprioception. There is one thing that is called osseoperception, which is something little bit mediating to the absence of proprioception. So a tooth and an implant are, of course, two different things, no doubt about this. The point is, can we make a big difference in prosthodontic cases between implant cases or natural teeth cases? Actually, there are conditions where we have all implants, like the lady I showed you before with the 10-year follow-up. But most of the time in prosthodontics, we have cases where there are implants and restored dentition, or maybe we have implants in the posterior and natural dentition in the anterior, or maybe we have implants in the lower and a denture in the upper, or maybe we just have single implants within natural dentition. But actually, most of the time in treated patients, we have some implants, we have some prosthodontic on restored dentition, or we have implants in the posterior and we have treated dentition in the anterior, or like this other lady, we have a bridge here, we have a crown here, and we have a bridge on an implant here. So we have several different conditions. So it's not just implant occlusion versus natural dentition occlusion with prosthodontics. So where is the difference? It's not implant versus teeth. Actually, the difference in managing occlusion usually is a difference related to what we are doing. There is a big difference in prosthodontics on managing occlusion if you are managing one tooth issues or if you are managing a full mouth restoration. And basically, this is the most important point. And there are much more similarities between these two and between these two than between this case on implant and this case on implant, because of course the neurological point of view of this one and this one is totally different. Here we have implant occlusion on one tooth, but we have a lot of teeth around, so proprioception is okay. Here we have no proprioception at all. So the big difference, normally, it's not implant versus natural dentition. The big difference is a small case or a big case. And actually, in a small case, that means when the patient has his own maximum intercuspal position, which is stable, there are no issues. Whether it's an implant case or a crown case, it's not a problem. While the point is that when we have a full mouth case, of course, we need to manage things according to a new therapeutic kind of occlusion. That means that normally, in a single unit case, whether it's an implant or it's a crown, we just have to follow the existing maximum intercuspal position. So we are not building a new anterior guidance, we are not building lateral guidance, we are not changing anything. We are just adapting within the framework of existing occlusion. In the cases where we are rebuilding everything, we are building a new therapeutic occlusion. That means that we are trying to make anterior guidance, lateral guidance, we are trying to avoid contacts in the posterior area, lateral contacts, because we are using artificial materials. Actually, this is not the way natural dentition is working. An articulator, of course, is not a reproduction of the mouth of the patient, but an articulator is something that is necessary when we are building a therapeutic occlusion for a patient. On implants, within that big division, keeping maximum intercuspal or going to centric relation treatment, when we have implants, we have some specific issues. Actually, some of these issues are related to what I call software. That means the way the central nervous system is managing occlusion. So there are issues related to proprioception, and there are issues related to motor control when we have implants. And on the hardware point, that means all the hard things, there are some issues related to what can happen to a prosthesis or an implant when there is an excessive load, and what can happen to bone level when there is excessive load. So actually, we are having some points on these issues related to implant. So as I told you, hardware is everything that is related to morphology, while software is everything that is related to the way the central nervous system is managing things when we chew, when we bite, when we use our dentition. So as far as software, the most important thing is that our central nervous system has something that is called cortical neuroplasticity. Cortical neuroplasticity means that our patients are adapting to our treatments. So when the central nervous system is working properly, we place in the mouth of the patient a lot of restoration, a lot of metal, resin, porcelain, all this stuff, and the patient is adapting to all this stuff that we are placing in his mouth. And he is adapting, of course, because things have been done in a proper way, but he's adapting because his central nervous system is working. So when we have a full mouth case with implant, the most important thing is not that, let's say, we have a cuspid guidance, because there is no cuspid here, there are implants, so there is no cuspid function, absolutely. The important thing is that we have a good distribution of contacts, and the most important thing is that the central nervous system has cortical neuroplasticity that helps to adapt to treatment. When it comes to osteoperception and jaw motor inputs originating from osteointegrated implants, the point is that if we consider a patient with full dentition, there are a lot of informations going from the teeth to the central nervous system. And if we consider an edentulous patient, In this case, we have no information going to the central nervous system. So when it comes to an implant patient, actually, we have several different possible conditions that are normally related to how many implants we have. Usually, if we have one implant, or even if we have more than one implant, but there is still a lot of natural dentition, usually these patients are working exactly like a natural dentition patient. That means that if you have 32 teeth and you have a lot of information coming from these teeth and you miss one, your central nervous system is working 99% the same way. That means that a lot of information are coming. It's not a single unit problem, but everything is working. Of course, when it comes to full mouth treatment with implants, what we have is that we have an edentulous patient with teeth. And this can lead to problems. Problems means more breakings, because with no proprioceptive information, we can have a lot of more breakings, more things not working. So what is osseoperception? Actually, there is a definition of osseoperception that goes back to Brannemark. It was a term proposed by Brannemark to recognize oral kinesthetic perceptual abilities in the absence of a functional periodontal mechanoreceptive input. So the point is that osseoperception is something that is more related to the typical old Brannemark cases. What does it mean? Edentulous patients treated with implants. The point is that if you have a fully edentulous patient and you place implants, at the time of Brannemark, they created this term to recognize the fact that they still can function, even without proprioception. But actually, osseoperception is a term that has no meaning if we are talking about single tooth or single implants, because with all the proprioception of the other existing dentition, there's no problem with osseoperception of a single tooth. So when it comes to software issues, to the way the central nervous system is managing occlusion in implant patients, there are probably big differences in larger implant-supported rehabilitation, where we have no teeth at all or we have few teeth. While in smaller treatments, single crowns or FPD occluding with natural dentition, the amount of missing data is not so relevant. So in a limited case, one implant, 4 implant, a bridge-on implant, there is no issue with the way the central nervous system is managing things. It's not creating any problem. When it comes to hardware issues, the point is that we can have things breaking. We can have screw breaking, we can have implants breaking, and it's more or less the same thing that can happen on prosthesis on natural dentition. Actually, the point is that with the rigidity of implants, these things can happen with more frequency than on natural dentition, because, of course, restored natural dentition has this mobility that can reduce the mechanical stress. With implants, we have no mobility at all, so the mechanical stress goes directly on the component of the restoration, and it can break the restoration. So years ago, people tried to do things to mimic nature, and for example, they used to place this kind of Teflon inserts to make things more flexible, but the point is that they used to break even more than without this type of stuff. So mimic nature is not always a good point. I want to show you one thing that I've been doing in the last 5 years. Actually, this is full contour zirconia on implants. This was the old bridge, it was failing. We placed 2 implants here, and we did this 2-unit bridge, this one and this one, on 2 implants. And this is full contour zirconia, directly screwed to the head of the implant with no metal insert. It's just zirconia going all the way to the head of the implant. And this is after 2 years. And you can see that the bone level is doing pretty good. And this is an extremely rigid type of connection. And this is another one. This is full contour zirconia, and you see here the bone level, and you see here, this is 5 years. This is all zirconia directly to the head of the implant, external eggs, no metal insert. So it's just zirconia all the way. And using just zirconia makes things very easy for a all digital model-free workflow. That means that if you are not using any metal insert, you can just do a scan and do full zirconia directly to the head of the implant without making a model. So this is what I call no abutment, no time, all digital model-free workflow. That means you screw directly to the head of the implant. So when it comes to hardware, we were saying, what is happening? With Daniele Manfredini and Frank Lobezu, we published this systematic review of literature in clinical implant dentistry related research in 2014. And actually, we looked for this question, is bruxism a risk factor for dental implants? And we reviewed the literature. And the conclusion, according to literature, is that bruxism is unlikely to be a risk factor for biological complication. That means that there is no damage to the bone implant interface coming from bruxing. But there are suggestions that it may be a risk factor for mechanical complication. That means that you can have more problems to the prosthesis in a bruxer. So actually the point is that nothing seems to happen to the bone level if there is an excessive type of load. And if we look at available experimental animal studies, we can find some studies giving a positive relation between bone loss and load level. So some people used to say that if you have excessive load, like for example in a bruxer, you can have marginal bone loss. But most of the studies done on animals did not find any relation between bone loss and load level. That means that you can have very high level of stress and no damage at all to the bone. The bone can even get better normally when you have high level of stress. So bruxism is not a risk factor for osseointegration. It can be a risk factor for failure of the prosthetic components. There are also some studies that have been looking to the effect of overload in relation to peri-implant microbial infection. So somehow they try to look at what is happening if we have inflammation and we have excessive load. But these are, I think, not that important to look in detail, and you can find them in the Dental XP website presentation. So in the end, how do we manage occlusion when we have implants, like this case, we have a bridge on implants, or how do we manage occlusion when we have the case we started with, the case of the young lady with 1 crown on implant and 1 crown on a restored tooth? Actually, I have been placing these implants, I have been doing these crowns, I have been checking occlusion on this one and on this one exactly the same way. That means that I have been using the same type of occlusal paper. I have been checking to see that they had no excessive lateral contact. I have been checking that they don't have contact on the oblique surfaces, but in the center of the fossa. Exactly doing the same thing. I'm not a fan of light contact on single unit implants. You may be familiar with the concept that some people are saying that on a single unit implant you need to have light contact when the patient is biting. Actually, is it possible to have light contact forever? This is a case of a patient I treated several years ago with an implant on this bicuspid. And he went to study abroad, and when he went away, he had a provisional in resin. And when he came back, it was 4 years later. And actually, what had happened? The provisional had worn off, and there was some extrusion of the upper. So if you provide a patient with light contact on a single unit, actually, or you go and make light contact every 2 or 3 months with occlusal adjustment, or after a few weeks, there will be full contact everywhere. So I'm providing patients with full contact immediately. I'm just telling them that they may feel something different for a couple of hours, the same way as if they go in a shop and they buy a new pair of shoes, they will feel something for one day and then they feel nothing. But I don't think we can give a patient a crown that is not in contact and think that it can stay like that forever. So when you have implants and crowns, actually the same type of surface is on the tooth and on the implant, no difference at all. And what we are willing to avoid, actually, is we are willing to avoid sliding contact, because sliding contact is creating damage to the layers of our restorations. So the point is that we don't want lateral sliding contacts on any type of restoration. We don't want lateral contact on metal ceramic restoration. We don't want lateral contact on zirconia ceramic restoration. We may be less worried about lateral contact when it comes to monolithic restorations, because, for example, monolithic zirconia is an excellent material. Monolithic lithium disilicate, it's an excellent material. But then these materials have wear patterns that are different to enamel. So we better provide occlusion that is not giving sliding contact on any type of artificial material, because we don't know how is it going to wear. We know that probably it's going to break instead of wearing, because it's not enamel. So coming to the conclusion of this lecture, I have 3 minutes left to end my lecture. How do we manage occlusion? Of course, we manage occlusion according to old classic principles. Contact in the center of the fossa. We don't want contact on the lingual sides. We don't want all the things that you have been taught to avoid. And we want that to happen on implants same way as we want that to happen on natural dentition. So implants and teeth are obviously different from several points of view. And there are several reasons why we have to check carefully occlusion on implants. And I try to give you some of these reasons. But my point, again, is this one. Aren't we doing the same on restored natural teeth? Aren't we checking carefully to avoid negative or damaging type of contact? I think that we are actually doing exactly the same thing also on natural dentition.